Thank you, Nan, and welcome to everybody for this year's Day on the Hill pre-event webinar. My name is Rob Kramer. I'm the Director of Government Relations here at ENA. And over the next 45 minutes or so, Richard and I are going to talk with you guys about this year's legislative asks for Day on the Hill. We're very excited to be back in sort of our second year back after the pandemic, back in person. Very excited to welcome everybody, and we'll get underway with just one quick housekeeping announcement from the marketing team. We're very excited to let everybody know that EN23 registration has launched. So for everybody that's excited about going to San Diego this fall for EN23, we wanted to let everybody know that registration is launched, and the earlier that you register, the more you will save. But please hold off on registering until after the webinar. I have been assured that there will be space available for you, but you can go to www.ena.org/EN23. And then for more information about Day on the Hill, as well as a number of documents, including the one-pagers associated with the bills that we're going to talk about today, as well as instructions and other helpful items, you can go to the Day on the Hill event page, which the address is there on the screen. Another note on today's webinar, it is being recorded and it will be posted to this address, to the event page, in the next couple of days, hopefully by the end of the week. For anybody that missed something, or maybe had to run to the bathroom or go grab a snack or go walk the dog, you'll be able to review a recorded version of the webinar later. So without further ado, the 2023 legislative asks for this year's Day on the Hill include two bills that are both going to be active in the House and the Senate. The first piece of legislation is one that is familiar to many of you, especially if you've been to Day on the Hill before. It is the Workplace Violence Prevention for Healthcare and Social Service Workers Act. I'll be talking about that here in just a minute. We're very pleased to announce that both of these bills were reintroduced for this Congress yesterday. We just got bill numbers today. They are HR 2663 in the House and S1176 in the Senate. Very excited about that. So we're very pleased to have bills that have been just introduced. Our other priority, which Richard is going to talk about here in just a little bit, is the Improving Access to Mental Health from the Emergency Department Act. You'll see the HR and S numbers are blank. That means that the bills have not yet been reintroduced for this Congress, but we do expect for both of these bills in the House and the Senate to be reintroduced very shortly, hopefully before Day on the Hill, and we can provide bill numbers then. So like I said, Richard will talk about that bill here in just a little bit. So first on the docket is one that I'm sure that many of you are familiar with, the Workplace Violence Prevention for Healthcare and Social Service Workers Act. As I mentioned just a minute ago, it's HR 2663 in the House, sponsored by Representative Joe Courtney, who is from Connecticut. And in the Senate, it's S1176, sponsored by Senator Tammy Baldwin in that chamber. Just as a reminder, with the reintroduction of these bills, we did issue an action alert for the legislation that went out to the EN 4-in-1 Action Network last night. So if you're a member of the network and haven't participated in the action alert just yet, please do. And we're really looking to get our co-sponsor numbers up before Day on the Hill so we can give out a lot of thank yous then. So the way that we're going to talk about the legislation and our asks, as we've done in the past during these webinars, is we're going to talk a little bit about building the case for the legislation and why we need these bills in order to help resolve some of the issues that you guys are having at work or that your patients are having in receiving emergency care. So with workplace violence, we begin this by building the case by talking about the really alarmingly high rates of workplace violence that are experienced by healthcare workers specifically. And so we did this by talking about, the increasing rates of violence over time from 2011 to 2018. Government data showed that non-fatal violence against healthcare workers grew by 63%. So this shows that the problem has been growing over time. And then, of course, in 2018, this culminates with statistics that show that serious injuries related to workplace violence were 6 times higher than for healthcare workers than for other people in the private sector. So we start by building the case that pervasive workplace violence is a major issue that is acutely affecting healthcare workers specifically in the United States. Additionally, in 2018, and this is a new statistic for us, about 73% of violent injuries that required days off work in the workplace were committed against healthcare workers. So we've got an alarmingly high rate of violence that has gotten worse over time, culminating in much higher rates of violence for healthcare workers than for those in the private sector. And even the statistics that affect the economy, those affecting days off work, more healthcare workers are missing days off work because of violence than those in the private sector. And then we are coming out of the pandemic, but many of your meetings may ask what violence was like during the pandemic. And as we saw from research from a number of different surveys, violence did have an uptick during the pandemic. And the statistic that we're using is about 31% of hospital-based registered nurses reported increases in violence during the pandemic. Although if we were able to get responses from everybody, I would guess that that number would actually be quite a bit higher. So we've talked about the growing rates of violence. We talked about the current impact that it has specifically on healthcare workers. It's also good to talk a little bit about the impact that violence has on not only your working lives, your personal lives, but also on patient care. So you can talk about, the potential for injury or loss of life, specifically to emergency nurses when they are attacked in a violent way by patients and their family members. We can talk about how violence affects nurses through things like burnout, PTSD, the psychological impact that it has on you and your colleagues as you try to go and provide patient care day to day. And then we can also talk about the potential negative impacts that violence has on patient care. It creates a very unstable environment. It creates a very stressful environment for you to do your jobs. And ultimately, I think the argument can be made that it has a detrimental effect on the quality of patient care that's provided downstream. Then on top of this, of course, there are a number of economical issues that go along with this related to things like the staffing crisis and boarding that we also see in the emergency department. The high rates of violence contributes to nurses leaving their professions. That contributes to the staffing problem, boarding problem, et cetera, et cetera. So when we talk about the legislation, it's important to talk about the impact that violence is having on you and your patients, but also the specific impact that workplace violence is having on healthcare workers and on those in the emergency department, where ultimately your departments are open 24 hours a day, 7 days a week, and you're required by federal law to stabilize and treat the emergent conditions of any patient that walks through the door. So policy-wise, the way that we would tackle this issue is looking at what current law provides for workers against workplace violence. And so we look to OSHA and their national standards. Now, OSHA generally assures a safe and healthful working conditions for working men and women by setting and enforcing standards and by providing training, outreach, education, and assistance. That's from their website. But their job ultimately here is to provide protections for workers where they otherwise might not be protected. For us, in the workplace violence frame, this really kind of comes in the form of protecting workers before they're assaulted, but also after violence occurs and supporting them appropriately after the assault happens. There is no current national standard from OSHA related to workplace violence in the healthcare or social service setting. And so ultimately, that's what we are looking for from our legislation that we support. We need a national standard specifically for healthcare workers because workplace violence, through the statistics that we've shown, we have additional data, that workplace violence is a serious concern for the country. It's a serious concern for the government because they have an interest in keeping workers safe, as well as providing high level and high quality patient care to citizens across the country. There's a gap. There are no current federal requirements to prevent or respond to violence or that provide that your employers are going to take any steps to prevent or respond to violence. We could look at the states and what they've done, but states have ultimately been slow to respond. Every single state could pass a similar law requiring workplace violence prevention plans within their own state. Ultimately, less than 25% of states in the country have chosen to do so, and this is after years and years and years of statistics and advocacy, really honing in on what this problem looks like. And then the other thing we can say is that recent research does indicate that there is success from interventions like this when you do provide upfront workplace violence prevention plans that are have input and buy-in from the staff. They have been shown to mitigate the impact that violence has on the working lives of some healthcare workers. So ultimately, what we're looking at is the legislation here. And in a nutshell, what the Workplace Violence Prevention for Healthcare and Social Service Workers Act would do is it would compel OSHA to implement a national standard that would require healthcare employers and social service setting employers to develop and implement workplace violence prevention plans that identify and respond to known and potentially unknown risks, that document and investigate violence in an appropriate way that allows for better record keeping and better data collection and analysis, but really looking at building a more supportive environment for workers, providing resources when they're assaulted, maybe providing days off from a separate bucket of PTO, supporting them in filing charges against the individual, removing them from that patient's care. We hear so many stories about patients or nurses that are assaulted, and then they have to turn right around and continue providing, emergency care to that individual, or, stitching them up or whatever. So also looking at ensuring that all workers within the hospital or the emergency department have appropriate training and education on all aspects of de-escalation, mitigation, but also knowing what their rights are and knowing what their responsibilities are as witnesses and as victims when they are assaulted, so that we can get more prosecutions and so that nurses ultimately feel more supported in the workplace. Now, I do want to note, if you have any questions, I forgot to note this at the beginning. If you have any questions about the legislation that I'm speaking about, you can put them into the chat. We'll look to address any Q&A that we have here at the end after Richard's finished. So if you have any questions about the Workplace Violence Prevention Bill, go ahead and put it into the chat, and we'll be collecting those for discussion here at the end. But really, ultimately, what we're looking for here is, movement of this legislation beyond what we got in the previous Congress. It's going to be a tough road for us, as it has been in the past. In the last Congress, this bill was able to pass the House of Representatives with bipartisan support, although it was never considered in the U.S. Senate. Ultimately, if it doesn't get considered in the Senate, it can't be signed into law. In the current Congress, as I mentioned, it was introduced this week, yesterday. I don't know why it says last week. It's a mistake. By Representative Courtney and Senator Baldwin. And our goal for Day on the Hill is to get as many co-sponsors coming out of that event as completely possible, as humanly possible. With the bill just being dropped yesterday, it's likely that there will be a handful of prior co-sponsors that jumped onto the bill early, but we're going to have a great opportunity to get around in the House of Representatives and in the Senate to really, remind those members of Congress about their commitment to this legislation in the past, and to try to get their support to move it forward in the future. So when you get to Day on the Hill, we will provide all the normal materials, but in your welcome packet, we'll also provide a sheet that will not necessarily list out the co-sponsors from the last Congress. Certainly in the Senate, we will provide the co-sponsor list, but for the House, we're going to provide the vote list for the bill, because there were a number of members that didn't necessarily co-sponsor the bill that did vote in favor of it when it came to the House floor. Those are prime targets for co-sponsorship this time around. So our goal ultimately is to get as many co-sponsors as possible coming out of Day on the Hill, but we're really excited about this legislation. I can tell you that, just as a quick update, OSHA is moving forward and with the development of a potential proposed rule, which would not necessarily negate the need for legislation. Legislation is more preferable to us in this instance, because once the bill becomes law and the national standard is implemented and finalized, it is much more difficult for future administrations to overturn the enforcement of that standard, because it would have already been signed into law by the president through the Congress, through an act of the people, more or less. So much better to get it passed into law through legislation. But I do want to let you know that the wheels are turning very slowly on the regulatory side as well. So I'll go ahead and stop there and turn it over to Richard Moreau, who is ENA's Chief Government Relations Officer, for discussion of the next bill. Richard?
Thank you, Rob. So now let's move on to our other legislative requests for our congressional visits during Day on the Hill. So ENA's second priority is a bill we have not, unlike the workplace violence bill, it's a bill we have not previously supported. And this is a very targeted bill that addresses the issue of mental health care and the related issue of boarding in the emergency department. As you can see, the bill is called Improving Mental Health Access from the Emergency Department Act. As of this morning, as Rob mentioned, this bill has not yet been introduced. We do expect it to be introduced within the next several days, if not the next several days, certainly by May the 2nd, in both the House and the Senate. The House sponsor of the bill is Representative Raul Ruiz of California. While in the Senate, we expect the bill to be introduced by Senator Shelley Moore Capito of West Virginia. As you can see, this bill has bipartisan support. Representative Ruiz is a Democrat from California. Senator Capito is a Republican from West Virginia. This is actually a good thing because we need to have strong support in both parties to get the bill passed. And as you probably know, Congress is currently divided. The House has a Republican majority, and while the Senate is controlled by Democrats, so having both a Democrat and a Republican lead will actually help in getting this bill considered and passed in both the House and the Senate. So much like we did with Rob's bill, the workplace violence bill, I want to set this up by talking about the issue and the problem, and then moving on to talking about what's in the specific piece of legislation. I want to step back and highlight that the U.S., and this is something that I think you all know already, is experiencing a sharp increase in mental illness. And at the same time, our healthcare system does not currently have the resources to adequately respond. The first point is that 1 in 5 American adults are affected by some type of behavioral or mental illness. But at the same time, more than half, 56% of these adults do not receive any treatment. 11 million Americans have been diagnosed with what is defined as a severe mental health condition, and only 40% of this population is receiving treatment. Situation is really dire among young people. Only 27% of youth with depression receive consistent care. So we have a big issue, but we certainly have a shortage of adequate care. And just to highlight how severe the mental health crisis is, the suicide rate has increased in the United States by 34% just since the year 2000. Just a note here, you do not need to memorize all this data and all these facts and figures. As Rob mentioned, we have a one-page document on each of our bills. You have received this one-pager by email. The one-page summary can also be found on the ENA website, and a hard copy will be provided to each of you when you get to Day on the Hill on May the 2nd. So no need to memorize every fact and figure. As bad as the mental health crisis was before COVID, the pandemic has only made the situation worse. Multiple reasons for this, but some important factors that have exacerbated the problem include economic anxiety, social isolation, school closures, and of course, reduced access to mental health services. A lot of statistics we could highlight to talk about how much worse the problem has become since the onset of the pandemic. However, Kaiser did a very powerful study back in 2021 that found 40% of adults reporting symptoms of depression or anxiety. That compares with 10% pre-pandemic. Again, young people really impacted by the COVID-19 pandemic. 25% of 18 to 24-year-olds had seriously considered, and that was actually the wording in the survey, seriously considered suicide in the previous 30 days. That's a CDC study from August 2020. And the following year, CDC did another study, and the results were unfortunately also very problematic. It showed that among 12 to 17-year-olds, ED visits, specifically ED visits for suspected suicide attempts, had increased by 39% in 2021 versus the same period in 2019. And then they broke it out among boys and girls, and the increase was 51% among 12 to 17-year-old girls. Again, all this information is found on the one-page document on the bill, but I think these findings, however, really underscore why this legislation is urgently needed. This next slide focuses on the impact of the mental health crisis on boarding and overcrowding in the ED, subjects I know that you are very familiar with. So we know that lack of access to mental health services leads to greater utilization of EDs, and the problem has worsened over time. The percent of ED visits for mental health specifically has gone up from 6.6% in 2008 to 10.9% in 2016. That's a really sharp rise in the period of 8 or 9 years. Obviously, as you know, this leads to overcrowding and boarding as hospitals have a shortage of inpatient beds and outpatient resources are limited. This reliance on ED care obviously has a trickle-down effect on boarding because the average ED stay for mental health patients, and this is based on ENA research, average stay is 18 hours versus 4 hours for all other emergency department patients. And I think, as you all are well aware of, the ED, you all do the best you can to treat every patient, but it's a hectic environment, far from the ideal setting for taking care of patients with mental health conditions. And there's also considerable evidence that boarding compromises patient privacy. It increases the risk of medical errors, delays appropriate care, and often can lead to worse outcomes. And, getting back to the boarding issue, I would not take it for granted that Capitol Hill staffers or members of Congress even know what boarding is. So as part of your meetings, I would explain actually what boarding is. Some healthcare staffers certainly are familiar with that term, but many others may not be overly have worked in that area and be familiar with boarding. So after describing the severity of the mental health crisis and its impact on boarding and EDs, I wanted to go over what is actually in the bill and how it can help alleviate this ongoing problem. So the key element of the Improving Mental Health Access from the Emergency Department Act is the creation of a new grant program to be established by the Department of Health and Human Services. This program will provide resources to EDs to better connect patients experiencing behavioral health episodes with treatment options in their community, whether it's inpatient or outpatient. This is a competitive grant program, and it allows for maximum flexibility. We know that each ED has its own needs and all going to be different. So a lot of flexibility in how the grant program can be used and the funding can be used. Some examples that are cited in the bill for how the resources and funding can be utilized include expediting placement of patients in appropriate facilities, increasing the supply of inpatient psychiatric beds, and alternative care settings. And one such alternative care setting is community behavioral health clinics, which are being expanded across the country. That's a possible use of money from this bill, is to place people in community behavioral health clinics. The money can also be used for alternative approaches to providing psychiatric care, including telehealth and the creation of psychiatric emergency service units in local communities. And last, but certainly not least, is utilizing proactive follow-up for patients during the period of transition. This will help ensure that patients are getting the treatment they need after they are discharged from emergency departments. So this last slide, I wanted to go over the status of the bill and what the ask will be during your congressional meetings. So in terms of background, this bill was introduced in the previous Congress, which ended in December of 2022. It did pass in the House of Representatives with bipartisan support. This is something that you should feel free to mention, especially in your House meetings. The fact that it passed by a very strong margin in the House, I think demonstrates that this bill has wide-ranging support. However, unfortunately, this bill was not considered in the United States Senate. In this session of Congress, the bill, as Rob mentioned and I mentioned earlier, should be introduced shortly by Representative Ruiz and Senator Capito. We're pretty sure that will occur before Day on the Hill, and we will certainly provide you with the bill number as soon as that bill is introduced. It will likely be referred to the House Energy and Commerce Committee, which has jurisdiction over healthcare policy, and the Senate Health, Education, Labor, and Pensions Committee. What's really important is to focus on the request or the ask, and it's very straightforward. It's exactly the same in both the House and the Senate, and that request is for your representatives and your senators to support and, most importantly, co-sponsor this legislation. Your assistance, your help in getting co-sponsors is absolutely essential. This year in both the House and the Senate, a grand total of one person co-sponsored this bill in each chamber, one person. I believe that is the main reason why this bill did not get enacted into law or didn't get passed in the Senate. So this year, your assistance in getting additional co-sponsors will be essential to the bill's success and its passage in both the House and the Senate. So with that, I want to turn it back over to Rob Kramer to see if any questions have come in regarding either one of our two legislative asks. Rob?
Sure. So it looks like through the chat, we've got three questions. One's related to workplace violence. That's from Judy Marlowe. I'll go ahead and address that now. She asked if there was any requirement within the workplace violence legislation that would compel hospitals to reach out to law enforcement agencies, it looks like, and to educate within, I'm not exactly sure what catchment areas are, probably a term of art within the hospital, but there's nothing specific within the legislation that would compel hospitals to have discussions with law enforcement officers or agencies. But with the general provisions and requirements of the workplace violence prevention plans, there are a number of different items in there that have requirements regarding reporting and incident response, emergency management. Some of the execution of those provisions might end up naturally with facilities having a discussion with local law enforcement to determine, I think, primarily what the response should be from the employer as well as the employee, the victim, in my sense, to help ensure that prosecutions are going to be available, evidence collection, documentation, things like that. But it certainly can be a part of it. The plan, the requirements for the plans allow a lot of flexibility.
All right. Hey, Rob, I see another question here from Judy Marlowe.
Yep.
Is there any data on the number of people who use virtual access to care exclusively? This is problematic because it is challenging to effectively assess patients. I think Judy's referring to the Improving Mental Health Access from the Emergency Department Act because it allows money to be used for telehealth. Judy, I've not seen data on the number of people who utilize telehealth for access exclusively. I just want to note that this is not a requirement of the bill. It is purely discretionary on the part of the ED if they wanted to utilize telehealth or telepsychiatry. Maybe it's appropriate for some rural settings. It obviously is not appropriate for all EDs or certainly in all situations. So it's really up to the ED and it's discretionary when they use it or when they don't use it.
Richard, it looks like Carla Kelly also asked if there was more current data related to, I think, the percentage of ED visits that are related to psychiatric problems.
Carla, that's a great question. And I looked high and low for recent data. And that number, which I think the number was from 2019, 10.9% of visits are psych or mental health related. That report actually came out in late 2022, early 2023. So that is the most recent number I've been able to locate from any of the healthcare agencies of the federal government. I am still checking in with them to see if we have more recent data, but that is the most recent data that is reliable and that I was able to locate. But good question.
And then Ashley Barney asked about including veteran-specific statistics for the, I guess, the psychiatric bill. That's a huge problem in her state, given recent events over the last couple of years.
Good point, Ashley. I have not seen any veteran-specific stats. We'll certainly try to locate them. And just, a point that I think Rob and I probably should have made earlier about these studies and these statistics, these are really important data points to use during your meetings, but do not become overly reliant on figures or statistics. It's great to use them to emphasize a point, but you're being on the front lines of this crisis, whether it's workplace violence or boarding and mental health. It's your story, your personal anecdotes and experiences that really make a difference with legislators. That's what they remember. That is incredibly powerful in terms of persuading them to support bills. So absolutely, stats are great, but focus on the stories as well as statistics during your meetings.
Another question that came in, looks like from Adriana. I think she means representatives. The representatives that oppose 2663, which would be the workplace violence bill, make points regarding costs for implementation. What is the hurdle? Yeah, when you read the responses from organizations like the American Hospital Association that oppose this legislation, one of the things that they'll bring up is, a popular term, it's called unfunded mandates. And ultimately, this is kind of one of those, but it's staff time that's taken away the development of these plans. It doesn't require that they do a security review and then replace every single lock in the facility. It doesn't require that they put metal detectors or hire 24-hour security. All it does is it forces them to turn their heads around and look back at themselves and say, what are we doing to mitigate and prevent violence for our employees? Can we do more? And the idea is to get, within the bill, it talks about including and having buy-in from the staff. Well, that's an important part of this. Is it's coming to a sort of an agreement with the staff that this is what we are going to do collectively to address this issue without ignoring the problem wholesale or acting like it doesn't exist. That's ultimately where they're going to come at from the cost perspective. I don't really have a good response for that, other than I just don't think that it would come to the kind of burden that they would purport it to be. Rich, anything you want to add for that?
No, that's a good one. Hey, Rob, let me pose another question on the workplace violence bill in terms of possible objections. You may get a senator or representative who will say to one of our members, why not leave it up to the states to handle this situation? How would you answer that question, Rob?
Well, we have left it up to the states before. The states currently have the opportunity to pass similar legislation. And as we mentioned earlier, only about, I think it's less than a dozen of them have done so. And so we've given the opportunity to the states for so long. What we really need is consistent planning and a consistent environment, or at least a consistent expectation for workers as they go across the country, even as they go within their own state. The existence of workplace violence prevention plans, for those of you that are GA chairs that I've talked to, we talk about this every cycle. We go over this, and it takes a lot of work to get one of those bills passed. But even then, you have variation across the country. What we need is more standardization for this. We want nurses to know what they can expect and to know what their rights are regarding violence when it comes to the workplace. But yeah, they're taking too long, I think, is the short answer.
Yeah.
Way too long. And that's especially important if the people that you're meeting with were in the state legislature. You might bring this up to them that, they had opportunities to do something about this when they were in the state legislature and they failed to. And so we're asking them as, federal representatives and senators to act on it now.
Yep.
And plus, I don't need to sort of mention the fact that it's sort of a magic wand that when OSHA does it, it's everybody. Everybody counts now. It's not just, well, we're waiting for Kansas to get it done. Now we're waiting for Tennessee to get it done. And now we're waiting for Georgia or Kentucky or New York. It's done. So.
Any other questions? I don't see any in the chat box, Rob, but.
Does anybody have any regarding?
Anybody have any? Yeah.
This day on the Hill? Anybody have any fears or concerns or any other nagging worms that are burrowing around in your head that you want to ask about right now? We have our eyes on the chat.
One thing I did want to note for people is the day before our day on the Hill, the American College of Emergency Physicians are having their fly-in, and they're supporting several bills, including, last I was told, these two pieces of legislation. So you're going to be following on the emergency physicians in many cases, not obviously all meetings, but I wanted you to be aware of that because some of the staffers, some of the legislators may already have heard about it. I think it just adds more weight to our request, the fact that we're going in there in a unified fashion with the emergency physicians and supporting the same priorities.
So Carla asked what's happening on the morning of the 3rd. So the 3rd is Wednesday. That is typically, this year, we're going to have a continental breakfast to get you guys nourished. And then it's kind of up to you guys to get off the hill. That's the day for your meetings. Specifically within the agenda that you'll see on the website, we have a picture scheduled for 10:45 in the morning. If you don't have any meetings scheduled during that time, we would encourage you to come for the picture. That will be on the House Capitol steps. If you're reading a map, it's the south side of the Capitol complex. So if the Capitol complex is set up like this and the Capitol's in the middle and the Senate House is down here, we're going to be down here with the House. That's really unofficial, my air drawing. But then after the photo, for those that are available, we'd like for you to join us on the west side of the Capitol, which would be the other side of the building, for a media event that we are hosting, where we're going to talk generally about the state of emergency nursing, but really focusing in on our 2 pieces of legislation and how those bills would affect the emergency nursing work environment currently.
I see Emily has a question. Any advice when the office is not responding to multiple email requests for an in-person meeting? Emily, no easy answer to that. The only suggestion I have is if you try to go through the Health LA, then you may want to go to the scheduler or to go to the legislative director in the office. So if you're not getting a response from the Health LA, go to the LD, the legislative director, or to the scheduler. And if you're not getting a response from the scheduler or the legislative director, go to the health legislative assistant. So try different people. You can try calling, you can try emailing, multiple angles work. Any other thoughts, Rob, on that score?
I told Emily to shoot me an email. Let me know who it is. I can provide her with the scheduler, and if she doesn't have that information. But yeah, sometimes it can be a little bit of a push. Make sure that if you're a GA chair and you're requesting for the entire state, that you're sort of getting around the popular House response, which is if you're not a constituent, we're not going to meet with you. So make sure you mention that you're a GA chair representing the entire state.
Absolutely. Another thought, Emily, is when you make the request, mention how many ENA members reside in the state. That adds a little weight. If you can say I work, I represent ENA and we have 700, 500, 900 members in that state, I think that sometimes gets their attention as well.
There was another question about a piece of legislation I'm unfamiliar with, the Xylazine Act. Chuck Grassley, I'm pulling up this right now. Looks like there's a new, I don't know, Xylazine might be
I'm not familiar.
Veterinary drug that's now being abused. No, we don't have any position on that.
Deborah is saying this year is the first time I'm having trouble scheduling meetings. It's not my first time for Day on the Hill. Deborah, I'm not sure why. I know we have just concluded a 2-week recess. And if you were trying to make meetings maybe over the past 2 weeks, that could be a reason for a holdup. A lot of people have been away on travel or taking vacation over the past couple of weeks. They did return yesterday to Washington, many staffers and members. So that could be one reason. Elizabeth Gerhardt, I'm sorry. I'm having trouble securing a meeting with Senator Moran from Kansas. Appreciate help with that one as well. I'll drop you an email. Absolutely.
Yeah, even Deb mentioned some difficulty in getting meetings this year. And trust me, this is not Deb Choppy's first rodeo, as she mentioned here. But that was just us. But yeah, Deb mentioned that she's having difficulty too. Maybe that's what we can tell you. And I think we've mentioned this before. The House, unfortunately, again this year, the House is not going to be in session during Day on the Hill, just like it was last year. When that happens, when the boss is out of town, sometimes, and it really depends on each individual office, the staff can kind of have their own way with their schedule. So it might be individual staff decisions that it's coming down to. I would say keep being persistent and keep reaching out to somebody in the office. And especially if you reach out to the scheduler, oftentimes they sort of act as like a intermediate between the member and the staff. And so they might be like, well, you need to take this meeting because they're from the state and they're asking for it, so take it. So they can kind of help move the needle on that as well. So I guess for those that are having issues with the meetings, the order of operations here would be to try to identify a contact that's your policy contact, the health LA, as Richard mentioned. And then beyond that, perhaps a scheduler. If you're having difficulty, what I would do as sort of your first step, look up their website, find a local office to you, call the local office and ask them for the name of the DC scheduler and maybe even their email, and they'll probably give it to you. Say, I'm trying to schedule a meeting to DC. Can you give me the name of the staffer that would do that? And they might just hand it over to you. It's more difficult to find online. Like it's not going to be something you're going to be able to like Google search your way to getting. So my advice would be to call the office, ask them for who you're looking for, and see what they tell you.
Okay. Any other questions? I don't see any other ones. Deb, I see your message. We'll certainly help in any way we can, Deb Chaffee.
Yeah, and Deb mentions that they want, typically what the response that you might get from an email is that they want you to go to the website and put in your meeting request there. Follow their protocols. Make sure that you let them know that when you need the meeting for. It's not too late to even start requesting them right now and still get meetings with staff and even some members if they have time. So keep trying.
Okay, well, listen, I just want to once again thank everybody for attending this session, but even more importantly, thank you for coming to Washington, attending Day on the Hill, and advocating on behalf of ENA and emergency nurses and patients as well. As I mentioned earlier, your advocacy, we know, makes a real difference. We've actually tracked support and co-sponsors in years past, and we always see a surge in support immediately following your Day on the Hill meetings. On both these bills, getting co-sponsors, getting support is absolutely important. So thank you again for taking the time and the effort to come to DC for Day on the Hill. So we will see you on May 2nd, or maybe even the evening of May the 1st in Arlington, Virginia. Rob, any housekeeping things to finish up with?
I think we're good to go for now.
All right. Thank you, everybody. And we will see you in less than 2 weeks.